So after talking about the etiology and pathogenesis and different types of botulism and subtypes of botulinum toxin, let's now move on to another very important topic is epidemiology and clinical manifestations of botulism. And in this, we will discuss specifically about the epidemiology, and then we will discuss the clinical manifestations, how this condition manifests itself. And now we know it is neuroparalytic disease, cause paralysis of the nerve terminals by decreasing or inhibiting the release of acetylcholine. So, and then we also know that there are 7 serotypes of the toxin produced by the Clostridium botulinum. And then we will also, in detail now, we will talk about the manifestations of also the foodborne wound and infant botulism in this section. So first, the epidemiology of botulism. Botulism occurs worldwide. So it's a condition that is present throughout the world. But there are some causes of variation. And these causes are the actual differences in incidence. So there are some causes of variation, although this condition is present worldwide, but there are some differences in the incidence. In some areas it's more, in some areas it's less, but it is present throughout the world. Availability of resources to identify botulism. So we will talk about later on different conditions that needs to be differentiated from botulism. So if there is a limitation of resources, if some areas of the world they don't have the resources to identify or diagnose botulism, then naturally the incidence rate in that area will be considered low, because if botulism do occur, there is a failure to completely identify and recognize the condition. Then differences in reporting the requirements and limited external access to data collection. So all these are very, very important factors when we talk about the epidemiology of some disease. All these factors play an important role depending on the resources available for the collection of the data, how well they can report the condition, and what are different requirements for reporting the condition. Sometimes they are not completely fulfilled, and it causes the reporting is not as clear or is not up to the mark. No universal surveillance system is present for the botulism. So there is no universal surveillance that this needs to be followed up and this needs to be done. To capture the worldwide incidence of the disease, 30 countries currently participate in voluntary reporting of botulism cases. So you can see there is a very, very limited number of the countries, only about 30 countries that participate voluntarily in the reporting of the botulism cases. All the other countries, they do not report, and there is no way that we should actually know the incidence and the clear statistics about the botulism, although it is a disease which is present worldwide. to European Union through established surveillance system. So only 30 countries reported to the European Union, and they voluntarily report the botulism cases. Countries like Argentina, China maintain independent botulism surveillance. So there are 30 countries that report it to the European Union voluntarily, but there are some countries besides these who independently keep their record, and they have some type of surveillance system for the botulism. Foodborne botulism from 1899 to 2011, there are about 1,225 cases of foodborne botulism in the United States. Native communities are more affected by the foodborne botulism, illness associated with home canning practices. So one factor that can lead to foodborne botulism is home canning procedures, whether it's not the precautions are not taken to when the home canning is performed, but it is associated with increased cases of botulism. Consumption of home preserved fish or vegetable products can cause foodborne botulism. Next, wound botulism. First recognized in 1951. That's the picture of the wound botulism. Between 1943 and 2011, we have 491 cases reported in United States. Typical patient was 30 to 50-year-old resident of Western US with long history of black tar heroin injection. So patients who have a history of heroin injection usually develop wound botulism. In early 2000, associated with drug use emerged in Europe. Next, infant botulism. More than 3,900 cases reported worldwide of infant botulism. 84% are in the US alone. This disease first recognized in 1979. 80 to 100 cases commonly caused by serotype A and B, and we talked about these serotype A and B. A is the most severe type serotype, causes serious effect, and usually these patients require mechanical ventilation because of the effect on the respiration. And then B is also less serious than A, but it still can cause serious illness. Reported annually in the United States. So about 80 to 100 cases are reported annually in the US. Adult intestinal colonization botulism, difficult to confirm because poorly understood. And we already mentioned in the previous section that it's a rare illness, not very common, and it's poorly understood, so it's hard to confirm. No clear guidelines to differentiate it. Often these cases are caused by Clostridia variety type F, involvement of both Clostridium botulinum type A, Involvement of Clostridium butyricum type E is reported. So all these different types can cause the adult intestinal colonization botulism. Iatrogenic botulism. Iatrogenic is a term used for the self-induced, sometimes some procedures performed, some steps performed that can lead to the condition, and that's known as iatrogenic. Paralysis of variable severity occur in iatrogenic botulism, followed injection of licensed botulinum toxin products. Sometimes injection of toxin products can cause iatrogenic botulism. Injection for cosmetic purposes usually are not associated with the botulism. Next, inhalational botulism does not occur naturally. One report from Germany. Report has described botulism resulting from inhalation exposure to botulism toxin in lab incident. So in the lab procedure, lab incident, inhalation to the botulinum toxin is reported from Germany that leads to inhalation botulism. Intentional botulism. Intentional botulinum toxin has been weaponized. Aerosolization of toxin, contamination of food or beverages, unnatural event like unusual relationship between patients, atypical exposure vehicles or atypical toxin serotypes. So intentional botulism can also occur when it is used in the weapons and when it is aerosolization of the toxin, contamination of food and beverage. All these are the intentional botulism types. Now let's talk about clinical manifestations. We talked about the different types of botulism in detail. Common are foodborne, infant, wound. Then we have adult intestinal colonization. Then one case of inhalational. Then we have like iatrogenic and intentional botulism. But we still need to talk about what are the different features associated with the botulism. So clinical manifestation, how it presents, let's talk about that. Incubation period is 8 to 36 hours. Incubation period from the infestation to the appearance of the symptom, we have about 8 to 36 hours. Rapidly progressive illness can be as long as 10 days, so it's from 8 to 36 hours to about 10 days, dose dependent. If dose is more, it can cause early onset. If it is less, then it can take about 10 days. Symmetric cranial nerve palsies. It can cause paralysis of the cranial nerve. We have 12 cranial nerves, all perform important vital functions, olfactory, optic, then we have oculomotor, trochlear, trigeminal, abducent, facial, vestibulocochlear, glossopharyngeal, vagus, and accessory cranial nerves. So all these are 12 cranial nerves, 12 pairs of the cranial nerves, and they can perform different important functions, and these can be paralyzed. So symmetric cranial nerve palsies. Then we have bilateral descending, flaccid paralysis, descending from top to bottom causes the flaccid paralysis. Progress to respiratory failure and death. So botulism can cause death as a result of the respiratory failure. It can also cause a cranial nerve deficit like diplopia, dysarthria, dysphonia, ptosis, ophthalmoplegia, facial paralysis, impaired gag reflex, pupillary reflexes may be depressed. So all these are the effects caused by the cranial nerve palsies, diplopia, double vision, articulation is affected, dysphonia, difficulty in speaking, ptosis, drooping of the eyelid, ophthalmoplegia, movement of the eyeball is affected as a result of the muscle paralysis, facial paralysis, facial nerve, then impaired gag reflex, pupillary reflex also affected. So all these are caused by the cranial nerve deficits. Fixed or dilated pupils can occur. Dizziness, dry mouth, constipation due to paralytic ileus. Urinary retention is also common. Respiratory failure, weakness, nausea, vomiting, abdominal pain, reduced ability to suck and swallow, sluggish pupils, hypotonia, floppy neck, generalized flaccidity, and respiratory compromise. So all these manifestations, which are serious manifestations, can occur, but the main thing ultimately, respiratory failure can lead to death. Severe ptosis, we have expressionless face can also occur. Patient respond to question by moving fingers. They cannot express. Weak phonation of the patient, signs of mental status change, death due to airway obstruction, inadequate tidal volume, and paralysis of diaphragmatic and accessory muscles can occur. Preparing home canned food may assist with diagnosis. So if there is a history of preparing home canned food and consumption of those home canned food, very helpful in the diagnosis. Patient may or may not have wound or abscess. Suspicion of the diagnosis, history of injection drug use, or the presence of track marks. Clinical improvement follows sprouting of new nerve terminals, takes weeks to months. That concludes section 2 of our lecture. Thank you for watching sqadia.com.